Hello, I'm Randa Darwish. Pleased to meet you today to discuss redesigning the perinatal care during COVID-19 pandemic. Novel coronavirus infection is caused by severe acute respiratory syndrome coronavirus 2 and was named COVID-19 by the WHO in January 2020. The disease then spread rapidly throughout China and has now become a global pandemic. As of March 2020, more than 340,000 cases have been reported in more than 150 countries. The disease is primarily droplet airborne respiratory infection and is documented to have a strong human-to-human transmission. Up to date, there is no evidence of detectable viral load found in amniotic fluid, placenta, or breast milk. However, the atypical clinical presentations and two potential modes of transmission in neonates, maternal fetal or maternal neonatal, have led to diagnostic and management challenges. Due to physiological changes, increased oxygen demands, and immune suppression of pregnancy, pregnant women with lower respiratory tract infections may experience worse outcomes. Now let's revise some definitions. A suspected case is anyone with an epidemiological history and any of the clinical features, or all three clinical features, or severe acute respiratory infection with no other obvious cause. Epidemiological history is defined as history of travel to or residence in communities where cases were reported within 14 days prior to the onset of disease, in contact with viral RNA positive patient within 14 days prior to disease onset, in contact with patients who have fever or respiratory symptoms from communities with confirmed cases reported within 14 days before disease onset. Clinical features include fever and/or respiratory symptoms, imaging characteristics, normal or decreased white cell count with lymphocytes decreased. Close contact is defined as more than 15 minutes face-to-face contact or more than 2 hours in a close place, including households. A confirmed case is a suspected case with one of the virological or serological evidence. Reverse transcriptase PCR indicates positive for novel coronavirus RNA. Viral specific IgM or IgG are detectable in serum. Viral specific IgG is detectable from negative to positive. Viral specific IgG antibody reaching a titration of at least 4-fold higher in the recovery stage than in the acute stage. It seems that neonates are not the frontline cases for COVID-19. There is a limited number of cases reported to date where pregnant women have contracted COVID-19, all in the late third trimester, and nearly all delivered days after symptom onset. Mostly experienced mild or moderate cold flu-like symptoms. At present, some experts suggest that the fetus is unlikely to be exposed during pregnancy. Transmission of the virus was accordingly suggested to occur postnatally. However, some studies show that neonates born to mothers with coronavirus disease in Wuhan City tested positive for severe acute respiratory syndrome or coronavirus 2. Up to date, the number of confirmed neonatal cases is limited. So far, 6 cases have been reported in China. All 6 reported cases presented with non-specific clinical symptoms or signs that did not require intubation and were discharged after complete recovery. However, the progress of neonatal COVID-19 can change dramatically during the follow-up. In Connecticut, USA, a 6-week-old baby is thought to be one of the youngest deaths linked to coronavirus. Finally, it has been stated that the vertical maternal-fetal transmission cannot be ruled out currently. Children and newborns are not entirely exempt from the epidemic. Therefore, it is crucial to screen pregnant women and implement strict infection control measures, quarantine of infected mothers, and close monitoring of neonates at risk of COVID-19. Information may change as knowledge evolves. For perinatal risk management, we need containment, infection prevention and control, and other risk minimizing strategies. Containment is limiting or confining the risk. It aims to slow the spread of the virus, reducing peak demand on healthcare services, and allows care to be provided to more women and their families during the outbreak. It includes screening before arrival by phone or telehealth, triage in a location separate from the usual hospital routes of admission or assessment, and providing and recommending the use of surgical face masks to women at face-to-face contact. During the COVID-19 pandemic, many pregnancy-related services could be delivered via telemedicine. It includes consultation with specialists for maternal fetal medicine, genetic counseling, online communication with providers, mental health care, lactation support, and virtual postpartum visits. For infection prevention and control, follow the general health recommendation and public alerts for infection prevention control, isolation, specimen collection, and use of personal protective equipment. For routine maternity care, including labor and birth, use droplet contact and standard precautions, surgical mask, long-sleeved fluid-resistant gown, gloves, and eye protection, face shield or goggles. During aerosol-generating procedures, use airborne, contact, and standard precautions. Fit-check P2 or N95 face mask, long-sleeved fluid-resistant gown, gloves, and eye protection, face shield or goggles. Aerosol-generating medical procedures include intubation or extubation, cardiopulmonary resuscitation, respiratory supportive therapies including high-flow nasal cannula, CPAP, non-invasive mechanical ventilation, nebulized therapy, open airway suctioning. Nasopharyngeal swab or aspirate is not an aerosol-generating medical procedure. Other risk-minimizing strategies include recommend and inform mothers and their families about hand hygiene with soap and water for 20 seconds or with alcohol-based hand sanitizer or gel, face mask use, coughing and sneezing into elbow, social distancing, stay 1.5 meters from other people, and avoid close contact, using dedicated personal equipment and resources, cleaning and sterilization of surfaces and equipment, rationale for visitor restrictions, and risk minimization strategies for the postnatal baby care. The previously mentioned measures can be utilized at 3 levels. Tier 1, that's the standard or universal precautions for all patients regardless of the diagnosis. Tier 2, transmission-based precautions when disease is known and infectious. Workers require protection from the disease. Tier 3 or tertiary, patient protective precautions when patient is high risk with low resistance and requires protection from the environment. Level 3 includes negative pressure wards, typically in isolated buildings, reserved for severe infectious disease admissions. When possible, infected or suspected neonates are admitted to this ward, and the neonatal ICU team would be responsible for the infant's care. There, these neonates are also placed in incubators to reduce the potential of airborne transmission between patients and healthcare personnel. Considering the antenatal care following hospitalization for confirmed COVID-19 illness, further antenatal care should be arranged after the period of self-isolation for the acute illness. Referral to antenatal ultrasound services for fetal growth surveillance is recommended. This is 14 days following resolution of acute illness. Although there isn't currently evidence that fetal growth restriction is a risk of COVID-19, 2/3 of pregnancies with SARS were affected by fetal growth restriction, and the placental abruption occurred in a MERS case, so ultrasound follow-up seems important. This flowchart is used to assess COVID-19 risk in maternity unit attendees. At first check, does the mother have any known COVID-19 or symptom of cough or fever? If no symptoms, then no further action, and do the usual care. If there are symptoms, then give the mother surgical face mask and ask to put on. Accompany to designated isolation room or area for initial assessment. Use full personal protective equipment and infection control measures. Then further assess, does the mother have any emergency obstetric issue or is she in labor? If there is no emergency obstetric issue and she is not in labor, then advise to take on personal transport home immediately and self-isolate for 7 days, or attend the hospital's designated containment area for next action. Rebook any appointment after 7 days and send by post. If the mother is in an emergency obstetric issue or she's in labor, then alert designated local team, midwife, coordinator, obstetric consultant on call, and neonatal team. Midwife and obstetric doctor review within 30 minutes. Does she require admission to the hospital? If no admission is needed, then advise to go home as before. If she needs admission, then discuss with local designated COVID-19 team regarding best place for care. Test the mother for COVID-19 and treat as though confirmed case until the results of the swabs are available. Delivery room neonatal management for a mother with coronavirus infection. Once settled in an isolation room, a full maternal and fetal assessment should be conducted to include assessment of the severity of COVID-19 symptoms, which should follow a multidisciplinary team approach, including an infectious disease or medical specialist. Maternal observations, including temperature, respiratory rate, and oxygen saturations. Confirmation of the onset of labor as per standard care. Electronic fetal monitoring using CTG. If the mother has signs of sepsis, investigation and treatment are performed accordingly, but also consideration of active COVID-19 as a cause of sepsis should be considered. During labor, the following members of the multidisciplinary team should be informed: consultant obstetrician, consultant anesthetist, midwife in charge, consultant neonatologist, neonatal nurse in charge, and infection control team. Minimize the number of staff members entering the room. There is evidence of household clustering and household co-infection, so asymptomatic birth partners should be asked to wash their hands frequently. If symptomatic, birth partners should remain in self-isolation and not attend the unit. There's currently no evidence to favor one mode of birth over another, and therefore mode of birth should be discussed with the mother, taking into consideration her preferences and any obstetric indications for intervention. Mode of birth should not be influenced by the presence of COVID-19 unless the mother's respiratory condition demands urgent delivery. This flowchart shows the neonatal management when the mother has confirmed or suspected COVID-19. But let us first agree that a neonate is considered symptomatic if there is unexplained fever, respiratory distress that could not be explained by respiratory distress syndrome, transient tachypnea of the newborn, or sepsis or pneumonia from a known source, that is, identified bacteria or virus. So, when attending delivery and the mother has confirmed or suspected COVID-19, the room should be of negative pressure if available. It should be equipped with protective equipment, and resuscitation is done per the neonatal resuscitation program. Delayed cord clamping is not recommended, and unfortunately, mother-baby contact is not advised. In cases where the neonate is asymptomatic, he goes to the quarantine ward, tested for COVID-19, and tertiary prevention mentioned before is applied. If the neonate is symptomatic, he is transported in special equipped transport system with protective measures done. tertiary prevention is applied and transported to quarantine ward equipped according to his condition. And immediate COVID-19 testing is done. If the asymptomatic neonate confirmed negative, then routine care is done. Conservative approach in ward quarantine until completing 14 days. If the symptomatic neonate showed a positive test, then continue quarantine for at least 14 days, negative pressure room if available, and managed by staff trained specifically on COVID-19. Tertiary prevention is done and placement in incubator. Use of donor milk and multidisciplinary team is arranged. Special airway management if intubated and emotional support of the family. Discharge home when stable and 14 days quarantine is completed and continue on follow-up. The handling and disposal of diapers is extremely important. It was recently reported that children with COVID-19 have prolonged fecal viral shedding for several weeks after clinical recovery. It is still not known whether this viral shedding can lead to transmission of disease. Proper handling of diapers with stools or other secretions, especially respiratory, is potentially an important measure for decreasing the possibility of disease spread, both within the unit and after discharge. It's currently unknown whether a bath would alter the risk of potential transmission. Generally, infant feeding includes breastfeeding, pumping, compo feeding, formula feeding, any bottle feeding. Practice social distancing, wash hands often, avoid close contact with anyone who is coughing or sneezing. As for neonates born to mothers with confirmed or suspected COVID-19, breast milk is the best source of nutrition for most neonates. However, there are many unknowns about COVID-19. Therefore, families should participate in the decision to use breast milk for infant feeding with the support of healthcare providers. During temporary separation, mothers who intend to breastfeed should be encouraged to express breast milk to establish and maintain milk supply. If possible, a dedicated breast pump should be provided. Prior to expressing breast milk, mothers should practice hand hygiene. After each pumping session, all breast pump parts should be thoroughly washed and the entire pump should be appropriately disinfected per the manufacturer's instructions. The following precautions should be taken to limit viral spread to the baby: hand washing before touching the baby, breast pump or bottles. Avoid coughing or sneezing on the baby while feeding, and considering wearing a face mask if available while feeding or caring for the baby. This is an example on how to clean a breast pump kit. Wash your hands, inspect and assemble, clean, store milk safely, clean pumping area, take apart, rinse, clean pump parts. This could be done by hand or in a dishwasher. Place the pump parts in a clean wash basin. Do not place the pump parts directly in the sink. Add soap and hot water. Scrub, rinse, and air dry thoroughly. Clean wash basin and bottle brush. If you will use a dishwasher, clean the pump parts in a dishwasher if they are dishwasher safe. Run the dishwasher using hot water and a heated drying cycle or a sanitizing setting. Remove from dishwasher with clean hands, and if the items are not completely dry, place items in a clean, unused dish towel or paper towel or air dry before storing. After cleaning, for extra germ removal, sanitize pump parts, wash basin and bottle brush at least once daily. Store dry items safely until needed. This is what you need for formula feeding. You need to make sure you clean and sterilize the equipment to prevent infection. Sterilizing equipment can be done by cold water sterilizer, microwave or steam sterilizer, or boiling. Considering neonatal outpatient follow-up, before discharge, every parent is informed of the potential harm of indirect hyperbilirubinemia, the importance of bilirubin monitoring, and availability of online resources. Methods for assessing a newborn infant are also explained. In addition, families are provided with detailed information about COVID-19 and prevention strategies. A smartphone application can be helpful to monitor the transcutaneous bilirubin levels of discharged patients. Prior to discharge, parents download the app on their smartphone and practice using it. They receive a color calibration card for use at home. The image data are then transmitted to the cloud for analysis, and the results of the transcutaneous bilirubin level are provided in seconds. Before the online follow-up meeting with the pediatric provider, parents are asked to check the transcutaneous level and also complete a questionnaire about their infant's general clinical condition. Parents can also assess the degree of jaundice by observation in natural light. For infants with significant hyperbilirubinemia, hospitalization is recommended rather than outpatient daytime phototherapy to minimize infection. Parents are also given advice about neonatal follow-up and taking essential measures. These are different ways by which parents can check the weight and plotting the measurements on appropriate growth charts. Also, temperature and respiratory rate are monitored and recorded. And all these data are gathered to be evaluated at the next telemedicine meeting. I was lucky to find these references that I used in the presentation. And thank you very much for your attendance.